community health workers are vital to progress against malaria, yet this resilient workforce have not been given the due recognition they deserve. So we are very grateful to the panelists today for making it possible for us to hold this event. And whilst we're waiting for the rest of the people to connect, I may kindly ask you to pay attention to the housekeeping. Sonia, can you share that slide, please? To the housekeeping for the meeting. Yes. So the simultaneous French interpretation. So you can go to the interpretation button and click on the language French, if that's how you like to listen and follow the event. And please use the Q&A button to send questions you would like to have answered. At the end of the session, we'll have a Q&A session. And I think now I can go ahead to just start really. Like I said earlier on, the community health workers are vital to progress against malaria. And the objectives of this meeting is to advocate for what's needed for community health workers to play their roles efficiently. We want to highlight the challenges associated with the community health workers models. There are different models around. And we want to show how the different models could be made equitable and more sustainable. And last but not the least, we really want to advocate for community health workers being made professional, because it is really, really worth it for us and not only for malaria, but for the health system, really. So the Q&A questions, like I mentioned earlier, will be at the end. And please use our social media handles on the slide. On the top, you would see the different handles we have for sharing media. And I'm very happy to introduce our chair, Abigail Pratt. She's a senior program officer at the Bill and Melinda Gates Foundation. She's also part of the strategic partnerships and country engagement team, and leads the portfolio dedicated to improving access to quality case management in the public, private, and community sectors. Before the foundation, she spent a number of years as a technical advisor at PSI in Sub-Saharan Africa, Southeast Asia, and South Pacific. And we're really, really happy to have her joining us on today's event. Without much ado, I hand over to Abigail to chair the function.
Wonderful. Thank you so much, Nana. Oops, a little bit of echo, and we're good. It's an absolute pleasure to be here with you all today. I'm so excited that we're having this conversation and that there's so many of you who are joining from around the world. We are absolutely delighted to have such fabulous presenters and panelists. We're going to be hearing about sustainability and challenges in malaria prevention, specifically from a CHW perspective, which is unique. We're going to be hearing about the role of CHWs in accelerating progress toward disease elimination. We're going to be hearing about the criticality of actually counting CHWs. How do you do it? Why does it matter? We have a wonderful additional late breaker where we're going to be hearing about Liberia's national community program and the impact on malaria. And we're going to close out with a final session on how do you actually improve the management of community health worker networks. So the way that we are going to move through the session is I'm going to do individual introductions for each one of our panelists right before their session. So you'll see their slide pop up, give it a moment just to settle in. I'll do the introduction, and then our panelists can roll into their sessions. And as Nana mentioned, please do use the chat to ask questions. Hopefully this will be a very interactive session. I know a lot of you have extensive experience in this area and probably have a lot of comments on how we can work collaboratively to do better in this space. So without further ado, let me introduce Margaret Odera, who is coming to us definitely from the most beautiful setting today. She is a devoted community health worker under the Ministry of Health in Kenya. She's an organizer within the Community Health Impact Coalition, focusing on mobilization, sensitization, referrals, and follow-ups, especially on HIV-negative babies. As a CHW advocate, Margaret leads the CHW Champions Network, unifying over 6,000 CHWs nationwide and really spearheading efforts for their professionalization. She's driving the making of a national CHW association, which I look forward to hearing more about, and already garnering the support from 43 countries. Her advocacy has led to significant government responses since 2020, and she was honored as Heroine of Health in 2022, inspiring women to advocate for themselves with the belief that #ItIsPossible. And as Nana says, please do use the social media handles for this presentation. But let me pass it off to you, Margaret. Thank you so much for joining us today.
Thank you so much. It's such an honor to be here. And on the behalf of all the community health workers, I just say that it's such an honor. They are very much excited to be here. I know some of them are going to be in our midst. So I really appreciate this moment. Now, I take this opportunity again to thank MESA for giving the community health workers this opportunity to just present ourselves in this forum. Now, as we are going to talk about malaria, as the temperatures rise globally, the impact of climate in the transmission of vector-borne diseases such as malaria becomes extremely evident. As the place that I am in Homa Bay County, and this is a malaria zone. There are a lot of mosquitoes in the place that I am in. This is a tropical area. And I would like to, as I'm going to speak about this area, this is my second home. And it's very, very important that we have discussion of this subject because malaria has been ignored since the time of COVID. So as the temperature rise globally, the impact of such as Hello, can you hear me?
Yes, we can now, Margaret.
Okay. Let me start. I wish to thank MESA for this great opportunity you have given unto us, the community health workers, to air our views. This has been given to us as community health worker. It is the way to go because you will get the glimpse of the reality on the ground. As the temperature rises globally, the impact of climate on the transmission of vector-borne diseases such as malaria has become increasingly evident. I recount my recent diagnosis of malaria on 2nd January 2024 after experiencing severe nausea, joint pains, and headache. A community health worker in Homa Bay County, where I am right now, escorted me to the nearby health center. I tested positive of malaria, and being immunocompromised and knowing the relationship between malaria and HIV, I had to have immediate attention, medical attention. Thanks to the CHW who responded quickly and taking me to the doctor immediately for the treatment. During these critical times in Kenya, in the absence of doctors in the hospital in Kenya, patients have to look for doctors who could treat them at home. Community health workers play a vital, critical role in such times where temperatures are rising in Kenya and heavy rains are present. Therefore, refresher trainings about malaria is needed. The presence of pandemic like COVID and TB and HIV has overshadowed the fact that malaria is one of the killer diseases in the sub-Saharan Africa. Community health workers are members of the targeted populations. Therefore, specialized training is needed for us to be able to provide the needed health education in our communities. Community health workers work alongside with doctors and nurses in addressing health issues in our community. Constant professional support is needed from doctors and nurses so as quality service to the community is acquired. In outreaches, it is important to equip community health workers with essential protective gears and medical supplies under the supervision of our healthcare professionals. This will reduce overpopulation of patients in the hospital, hence saving lives and time. As community health workers promote community action for new activities, most of the time we lack protection from the government authorities. And some of us have fallen victims of attack and accidents. We are mostly on our own. Protection from the government authority is key so that we will effectively bring positive outcome of a stronger national health security. When a community health worker goes out, to the community with supply, it demoralizes her, especially when she comes across a sick person. Sick person will always be demoralized because prompt action will not be taken. Cultural barriers such as traditional beliefs have hindered success in tackling malaria spreading in Kenya. Misuse of nets also serves as a huge barrier in fighting malaria, as farmers use nets to cover farm nurseries. With the health education that community health workers have given, now the community has understood the importance of using nets when they are sleeping and not when they are in the farms. So the malpractice is gradually fading away. To ensure that every district or country is covered, equity in distribution of resources and pay is important. Distribution of equipment and protective commodities, such as treated nets, vitamin A, dewormers, and paracetamol are critical, especially during this rainy season now in Kenya. A healthy workforce automatically results in a healthy nation. Let us ensure that community health workers have a healthy salary, a healthy supervision, healthy supply, and healthy training. I commend the Ministry of Health. For now, we are receiving stipends. However, given that community health workers have started receiving stipends in Kenya, we still have challenges in equity in distribution of pay. The small pay that we have is not regular. It is also a great challenge knowing that the future of community health workers in Kenya and Africa is uncertain. We don't have job security. As critical role as we play, this uncertainty demoralizes the community health worker who works on the ground with passion. This issue is my greatest call to the leaders, stakeholders, and everyone who is listening. Together with the Community Health Impact Coalition, we are advocating for a salaried, skilled, supervised, and supplied community health worker. Thank you for listening to me.
Thank you so much, Margaret, for the presentation. That was absolutely fantastic and just so critically important for us to hear directly from you as a community health worker, having the lived experience and just sort of sharing your needs as you see them on a day-to-day basis. I think it's an incredibly powerful voice. So thank you for joining us. We are going to accept questions at the end. So let me just quickly roll over and invite Professor Evelyn Ansah, Director of the Center for Malaria Research at the University of Health and Allied Sciences in Ghana, who's a distinguished public health physician and epidemiologist recognized as a fellow of the Ghana College of Physicians and Surgeons and a Rockefeller Foundation Bellagio Fellow. She holds key roles at both the global and national levels, currently serving on the MPAG of the World Health Organization, the Independent Evaluation Panel of the Global Fund, and previously she served as vice chair of the Global Fund's Technical Review Panel and contributed to various WHO committees, including the Malaria Elimination Oversight Committee. Professor Ansah has also been actively engaged in research and capacity building, conducting studies on malaria case management, diagnostics, health systems, and maternal health. She plays a pivotal role in mentoring the next generation of public health professionals through adjunct lecturer positions and supervision of PhD and master's students. With numerous publications in peer-reviewed journals and contributions to the global health initiatives, Professor Ansah continues to be a leading figure in the fight against malaria and the advancement of public health worldwide. We are so delighted to have you on the line and look forward to hearing this important discussion about how CHWs can actually accelerate progress toward disease elimination. Thank you so much for joining us. Over to you.
Thank you. Thank you very much for inviting me. I appreciate the opportunity. I'm going to speak about the role of community health workers in accelerating progress towards disease elimination. Particularly, we are looking at malaria, and we'll be looking at the challenges that exist now, the opportunities and issues of sustainability. So I will be introducing the subject. I will highlight the role of community health workers, which has been ably highlighted in detail by Margaret. I'll talk about the challenges that exist, the opportunities that we have, and sustainability issues, and then I'll summarize. So we know that malaria is a problem that needs to be solved. Malaria is actually a problem, and it needs to be solved by employing the tools we have and the new ones we are developing. But we also know that it's not just about tools. The tools in themselves will not help us to get to where we are. Recently, also in recent times, WHO, recognizing this, has recommended a move away from the one-size-fits-all to an approach where proposed interventions and tools for malaria are tailored to various settings. So the critical question to ask is, what is the best way of solving the malaria problem here? Margaret was talking about the place where she was. Here in this particular context, this question cannot be answered without involving the community, because they hold part of the solution. So I'm showing you here community members involved in different aspects of healthcare. There's a discussion going on the right, specifically about malaria, which I was talking to them at the time. So, and no intervention, no matter how well tailored it is, will achieve the expected impact without the buy-in, the input, and the active engagement of the community. And the actual implementation of any intervention will be most effective when those who are implementing listen to and work with the community in partnership. We also know that elimination of malaria is possible, but only if the current rate that we are seeing, where things have stalled, is accelerated. And looking at community health workers, like we have heard just before, who live and work in the communities that they serve, they have a vital contribution to make towards accelerating the progress in the elimination of malaria, because we've already said that we must tailor things to where the problem is, and the community is critical. Talking about the role of community health workers, the ability to promptly, and I emphasize the word promptly, prevent, detect, and treat malaria infections in remote communities has been a driving factor in the tremendous progress that we have made against malaria since about the year 2000. And community health workers have proved to be vital to this significant progress. So recognizing this, there has been increased global investment in fighting malaria over the 2 decades. And this has included the training and scale up of a community health workforce that can reach the people who are living in remote and rural communities with the effective tools to prevent, to diagnose, and to treat malaria alongside other diseases. And in these places we are talking about, where malaria is a problem, oftentimes you are not going to find hospitals, you are not going to find clinics. These are the people on the ground. But the challenges, there are some challenges. The challenges are that we assume that every intervention, once proven, will work well everywhere. But we know that even mosquitoes keep changing their behavior. So since they are changing their behavior, and the weather is changing, climate is changing, temperature is changing, we cannot assume that an intervention that worked in one place will work well everywhere. We also assume that we as health providers are knowledgeable and have the technical know-how. The community should just listen to us, but this does not work. Sometimes we do not take our time to listen and understand what the community really thinks or anything we are doing, and use the information that we acquire as a springboard engagement. Also, we do not sometimes provide the needed support and to the community health workers we assign to ensure that the whole community are on board and are traveling along them. So sometimes they are trained, they go back to their communities, and we basically leave them on their own, either to swim or sink. And when they get discouraged, then they jump off as well. There are several community health service delivery systems also being implemented in various settings. And the lessons as well as the best practices are not being pulled together by anybody and shared so that others can learn from it. And in many settings, this vital workforce are not seen as an essential part of health service delivery. Their work is sometimes delinked from the formal health system and largely documented. So they are doing a lot of work at the community level. It never gets into the health information system, nor is it very strongly linked to the formal health system. And this is a big loss. Tools, logistics, and technical support from the health system in some settings is also ad hoc, resulting in their inability to function optimally and subsequently discouragement. The contribution community health workers make and its potential impact on progress in the fight against malaria is therefore not being harnessed effectively. And a lot of us who are health workers expect to be compensated for our time when we deliver health services, but we expect that community members must volunteer for free and forever. Community health information is also often a one-way street from the community health worker when they do their work. Feedback is not provided to them effectively in many settings. So you see this picture that I love very much, where data has, the people have done the work, they collected data, they submit it, and it goes away and they never see it again. They never get any feedback from the data that has been sent on what they are doing. But there are opportunities. It is well known that when malaria is eliminated, mortality due to other pathogens and causes also goes down as well. And this is an opportunity to home in on this. Reports from countries that have eliminated malaria also show that this could not have been possible without the contribution of the community health force. And this is well documented. The need to engage the community in service delivery is also being increasingly recognized globally. In recent times, community IPTP has been held up as the way to go to improve uptake of IPTP in many settings and has been documented to work. There's also evidence that care by community health workers, if documented properly, actually increases utilization of services. And female community health workers, such as indoor residual spray workers, actually serve as role models for their families, their communities, and influence health behaviors positively where they are. And there are best practices in countries where the role of this critical workforce has been recognized and integrated into the health system. So to ensure sustainability, there must be a deliberate effort to document and share best practices from implementation of healthcare at community level. The community healthcare system must be integrated into the health system and the documentation on what they are doing strengthened. A system that supports the career progression for community health workers who have the ability and interest must be considered very strongly. It's a very important thing, and this is one of the things that creates a problem and discourages them working and continuing to work. Adequate remuneration must be provided to this workforce in order to ensure continued motivation and sustainability of the services. Because if we do not remunerate them adequately, they will have to find the remuneration elsewhere because they also must live and look after their families. So in summary, eliminating malaria will require supporting and growing this resilient workforce to deliver to the at-risk communities tools that prevent, diagnose, track, and treat malaria. They are the boots on the ground, especially when we approach the last mile. And we must leave no one behind in terms of contributing to the fight against malaria and also in benefiting from proven intervention. To do this, we have to give due recognition to the critical role of community health workers and strengthen as well as integrate the community health system. So I want to thank you for your attention, and I'll stop here.
Thank you so much, Professor Ansah. That was absolutely fantastic. And I feel like we could spend the entire time talking about the various components that you touched on. I think the dual standards and expectations about compensation, the data going up into the air and never being utilized or seen again, gender issues. But I think the line that struck me most was that no intervention, no matter how tailored it is, which is something we talk about day in and day out, will ever be achievable or will ever impact without buy-in, impact, and active engagement of the community. So thank you so very much for those comments, and we'll circle back with additional questions for you.
Thank you.
Our next presenter is Dr. Maureen Momanyi, and she is a friend and collaborator, and I'm delighted to introduce her to speak to us about counting CHWs. Maureen is UNICEF's global lead for community health and a passionate advocate for advancing primary health care to the last mile. In her current capacity, Maureen works with governments, regional and country offices, and other stakeholders to institutionalize national community health programs for expanded primary health care with a focus on integrated multi-sectoral models that are tailored to address priority child health needs. Prior to this current role, Maureen was UNICEF's ESAR Regional Community and Child Health Specialist, providing leadership and technical oversight to key initiatives and national programs. And previously, she was working on the 1 Million CHW campaign at Columbia University as Deputy Director, providing strategic advisory, advocacy, and technical support. Maureen holds a bachelor's degree in medicine and surgery from the University of Nairobi and a postgraduate degree in public health with a major in epidemiology from the University of California at Berkeley. She is also a graduate of the Women Lift Health Leadership Journey class of 2021. Welcome, Maureen, and over to you.
Thank you, Abigail. Can you hear me? Okay, great. Thank you so much, MESA. Thank you for organizing this forum. And as Margaret said, giving us a floor to champion the role that community health workers play, particularly in delivering malaria services. Thank you, Evelyn, for your great reflections on the challenges and the roles that community health workers play. I will speak to why we need to count community health workers. And you will see, we started on a journey with Bill and Melinda Gates to tackle this question on, are community health workers actually delivering malaria services? What type of malaria services are they delivering, and where are they delivering these services? And what sounds like a very simple question to answer became a very difficult question, a conundrum of some sorts for us. And it's my privilege to be able to just walk you through some insights from this work. We'll touch a bit about the scope, the results, the limitations of what we set out to do, and the opportunity that's before us. So, as I have indicated, yes, we wanted to respond to a question on do community health workers provide case test and treat services specifically as part of the case management for malaria, particularly in malaria endemic countries in Africa? And if they are indeed providing these services, where are they? Can we provide accurate counts and information of these community health workers that would help us in better planning malaria programs? So we anticipated that we would be able to get this information, up-to-date information on who the community health workers are, the typology of services they are delivering, and by so doing, be able to strengthen or use this data to inform malaria programming, but even beyond that, go into the scope of supporting countries in managing their community health programs. And as a result, that we would then have better, more robust programming, especially from a workforce front. So how did we set out to do this? We looked at different measurement frameworks that exist. We looked at the WHO guidance document that sets forward the requirements that need to be in place for community health worker programs to be optimized. We looked at the measurement and accountability framework that supports the implementation of that guidance document. And then after that, a slew of various frameworks, including the Community Health Worker Assessment and Improvement Matrix, the CHW AIM tool as we know it, which is a great qualitative tool to assess community health worker programs, because we wanted to pull indicators that can help us track or answer this question. We then identified specific data domains. And as you know, yes, we want to get to the question of the services that they're providing, but it's good to understand the context in which they're providing these services, and hence the importance for us to look at governance, for example, look at financing, look at the type of community health workers, the counts within the various types of community health workers, look at whether they are trained, how they are incentivized, and the type of service package that they deliver. We had a couple of questions on supply chain and some questions on data use. As you can tell, we had quite a huge data set that we ended up with, but I will not share data from across all domains. I'll just select some that are pertinent to what we are discussing today. How did we go about collecting this data? So we started off with the premise of that the data is available and accessible at country level in some select countries in the Africa region. And for this data to be available, it means that somebody must have done the counting at country level and stored the data in a manner that we can be able to pull it out. And so what we're making reference to is that there needed to be a community health worker master list and registry in place at country level. We realized that because we were not going to go out to the field to collect raw data or do the actual counts because of just limitation of resources. But we said, okay, let's see which countries have the master lists and registries and draw data from this. We opted to go through the Ministry of Health because we wanted data that can be validated and can be made publicly available, that the Ministry of Health can own and therefore be empowered to use for to better enhance their program planning. We leveraged our UNICEF country offices and drew the data up to global level and then visualized the data on various dashboards. We note that as much as we were using the MOH reports as a single source of truth, we needed to validate some of this data, and some of our partners, and Harriet will come in later in our conversation, played a critical role in looking at the data that we were receiving and counter-checking and seeing whether there was alignment or not. So what were the results? We had 42 countries that responded to our survey tool, and all data, as I've indicated, was validated by our Ministry of Health. From these 42 countries, we were able to count 1 million community health workers, just slightly over 1 million community health workers. Now, 1 million is just a number, you may say, but what is it against? So we looked at the targeted number of community health workers drawn from national health plans and programs. So looked at, so how far are we in getting to the target? And you can see that we are close to 50% getting the target. And it was important for us to pull this 2.1 million target number because we know that the African heads of state gathered a couple of years ago and had an ambitious target to roll out 2 million community health workers over the continent to bridge the gap in the workforce at community level. So it was good to counter check this figure against that target that was given a few years ago, which was based off modeling. So we're almost halfway there. Then we looked at the sex disaggregation. Of these 1 million community health workers, how many of them are male, how many of them are female? Because we know that as we start to unpack the gender dynamics, the impact, the question, the points that have been raised by our previous presenters on protection, on social support, and other issues that empower or enable community health workers to deliver. Unfortunately, as you can see, not all countries were able to give us data that is sex disaggregated. Actually, only half, just slightly over half of the countries were able to give us sex disaggregated data. And you can see that there is a predominance of females in the workforce. But as you can see from my slide here, it depends on the country and the region. If you look at the West and Central Africa region, you see a predominance mostly of male community health workers as compared to the East and Southern Africa region. But then you can see also some nuancing from country to country. Looking at the policy and governance, because it's one thing to have community health workers, but under what policy banner are they working? Because that speaks to sustainability that Evelyn has pointed out, and also financing of this workforce. We saw that 37 countries, 88% of the countries had an existing community health worker policy-related document. And of these, 55% of the countries actually had national costed community health plans. And 47% of these actually recognize community health workers as part of the national health workforce, which made us sit up and say, okay, we need to amp up our advocacy. And that's why a forum like this is really critical, because many people may say, oh, you keep talking about this. You keep talking about the professionalization of the cadre. We keep talking about the recognition of the cadre. I'm sure there's progress that's been made. Yes, there is progress, but there's miles to go. On the question of salaries, we said, when we looked at the policy documents, we saw that only 30% of the countries had policy documents that actually spoke to providing community health workers with monthly salaries as part of the government wage bill, which of course, again, would enable then the sustainability of the remuneration of the workforce. Let's look a bit on the financing element. We were able to get some data on the status of national community health budgets from about 28 countries. And when you ask, what does it cost? Please don't take this figure to the bank, but it was just looking at the question on, okay, for the countries that have national community health budgets, how much of this, what does it cost from this budget? And you can see that it costs about 590, slightly over half a billion. But you know, for me, it says, yes, it is doable, because when you start to think about what does 590 million US dollars actually go to in other aspects of either in the social sector and beyond, even in the commercial world, we start to see that these are workable figures. They're not beyond our reach. But unfortunately, only 44% of these budgets are actually funded. We were not able to delve into the source of funding, or better yet, to go into expenditures, because that's where the cookie starts to crumble. When you look beyond the budget to actually how much our country is spending on community health, and specifically on community health workers. When it comes to remuneration and incentivization, I started off by telling you the story earlier on. We had 40 countries that provided some data on whether community health workers were receiving remuneration or incentives, non-financial incentives. So it's from the data we saw that 70% of community health workers received a type of financial remuneration. This is not salaries. This is just saying that they were able to get some sort of financial remuneration at the end of the day. On average, it was about $74 per month remuneration, financial remuneration. Again, this varied from country to country, and you can see the color on the chart tells you that it was a really wide range. There are, in terms of non-financial incentives, we saw that quite a number of community health workers do receive non-financial incentives, and these vary. And honestly, some of the things that we were counting as non-financial incentives should not be counted as financial incentive or incentives at all. They are a requirement. You know, we did count things like gumboots, for example. Margaret talked about the rains, umbrellas, the provision of protective gear. But then we pause and ask ourselves, this should not be incentives. They should not be counted as incentives. They're actually a requirement for community health workers to deliver. But nonetheless, it is clear that countries are keen on providing this, and they are provided to some extent. Let's look at training and deployment. We know that this is essential for community health workers to deliver. Now, here is where you start to see that the data starts to tell a very interesting story. We see that quite a number of community health workers do receive pre-service training. Lesser proportion receive in-service training. That is, so a good number, 92% of community health workers in 19 countries that provided the data said, okay, look, we are training our community health workers prior to them being deployed. But then we start to see that this training is not sustained as community health workers progress in the journey of delivery of services. And we note that, I mean, in any profession, including in any, especially in any health service delivery profession, there is a need for continued medical education. And so this is an area, an opportunity for us to strengthen, particularly around malaria service delivery. One may ask, what type of services do then community health workers deliver? This is increasing. We see 10, 20, 30 years ago, community health workers were delivering a very tight package, about 3 to 4 services. This has grown, and that's what we're trying to show on this slide. What's bolded out are some of the services specific or related to malaria, and you'll see that there are quite a number and they're quite interrelated, from malaria prevention and control to integrated community case management, going beyond that to neglected tropical disease prevention and control that we know sits very closely with malaria prevention. Honing in specifically on malaria-related services, we see that 41% of community health workers on the record provide malaria test and treat services. In 9 countries, this is 100% of the workforce, whereas in a subset of countries, community health workers are not providing malaria services, and various reasons, from the fact that maybe malaria has been eradicated or they're close to eradication in these countries, and the role of community health workers in particularly in test and treat is taking a back seat. But as then you can see from the chart that yes, indeed, community health workers are providing malaria test and treat services, increasingly so in countries that are malaria endemic. When it comes to stockout, again, Margaret reminded us that when community health workers set out to deliver services, when they go with empty backpacks or they do not have the test kits or the ACTs, it's really demotivating, of course, for them. And also we lose trust, the community start to lose trust in the health system. So we did put in a question on stockouts, but again, as you know, this is a very difficult question to answer. But nonetheless, despite its difficulty, countries did respond to the fact that there were stockouts in particularly for RDTs in quite a number of countries. But then again, we were testing out this particular question, and so there are limitations to how we can interpret these results. So, as you've seen, we've not been able to delve into all the data that we presented, But I hope that this makes a case for the fact that community health workers are providing community health, are providing malaria services at community level. It speaks to the importance of the need to count community health workers. What we present to you is a synopsis of what the data looks like at national level in some countries. It is limited to the fact that we were relying on Ministry of Health reports, which are critical and important. But it means that where there is limited alignment and coordination of service deliveries, then the data did not make it through. And so there may be implementing partners who are delivering services and doing an excellent job at it, but they're not being counted because of the need to strengthen coordination and alignment at national level. We do not look at sub-national data. You saw that there was a limitation in terms of disaggregation by sex. There was a couple of countries, about 3, that were able to give us disability data, for example. There was limitation in terms of financing. This is a question that we need to unpack further and go beyond budget data to actual expenditure data. And then on governance issues, as I've said, the issues of coordination at national level, the linkages between the national control programs, malaria control programs, and the community health programs, as well as PHC and programs and child health programs need to be strengthened. I think that is a story that we all know. There are opportunities. I won't delve into this. I think Evelyn touched on this excellently. But from a data perspective and the need to continue these counts and giving visibility to this data, which, by the way, will be soon accessible on the Rollback Malaria dashboard, there is a need to continue to do this, enhance the visualization and the use of this data, not just at global level as we are doing today, but also at regional and at country level, and move the data even closer to the communities and make sure that it's being used there. We will be working to expand the data. You saw data from a subset of countries in the Africa region. We'll be working to expand this data with our other stakeholders and include data from the Middle East, from North Africa, from South Asia, and also from Latin America very soon. And to use this data to inform the advocacy around better workforce planning, better workforce protection, and greater investments in community-based service delivery in an integrated fashion. And there are opportunities specific to malaria programming that can be leveraged, including the malaria vaccine rollout, the catch-up in high-burden countries, and closing the gap on zero-dose communities as low-hanging examples. I will stop here and pass it back to you, Abigail, and happy to take questions. Thank you.
Thank you, Maureen. I can speak from a very personal perspective and say that this has been an absolute labor of love. Maybe not a labor of love, but a labor for you. So I deeply appreciate your continued commitment to pulling together these incredibly valuable numbers. I think as the community, we need to think about how, Maureen talked about the fact that we've reached 1 million CHWs that have been counted and tracked, and how do we actually get to the full cadre, recognizing those that are actually working outside of the formalized Ministry of Health system, and then thinking increasingly about the fact that we can't come to this effort with our various silos and hats on. Of course, I look at this from a malaria perspective, and there are others who are going to be looking at it from a pneumonia or diarrhea perspective, and how can we sort of think about the CHW platform more holistically so we're not creating these artificial silos. So thank you so much, Maureen, for the presentation. I will move us along. We're doing quite well on time, so there should be ample opportunity for discussion, but I'd like to welcome Lassana Jabateh, Liberia's, the Director of Community Health Program at Partners in Health in Liberia. He leads a large team, including 7 partners in health staff and more than 200 community health workers that provide promotive, preventative, and curative healthcare services to the population. Lassana has an in-depth understanding of humanitarian work and years of field experience in managing and implementing health programs in crisis mitigation, recovery, transitional, and post-conflict. He's led the development and deployment of an innovative community health program that's currently being reviewed by the Ministry of Health on a national scale, so I look forward to hearing about that. He's designed and implemented a program for a new cadre of CHWs known as community health promoters, provide services to those living within the 5 kilometers of the nearest health facility, while those living further away might need more curative services. The CHP program focused efforts on providing health promotion and improving linkages to facility-based care. So thank you so much for joining us, and please, over to you for this interesting presentation. Nana, was I on mute that whole time? Are we good?
Hi, everyone. Thank you so much,
Okay, great.
Abigail, for that introduction. Next slide, please. So I will be talking about the Liberian Community Health Program impact on the fight of malaria. Liberia experienced Ebola, and this Ebola fight in Liberia helped to expose the gap of weaknesses in the Liberian health system. And among that, community health program was one of the areas that the fight of Ebola exposed, that Liberia did not have a standardized community health worker program. That make it difficult for Liberia as a country to be able to fight fight the Ebola in the community. And during the Ebola, there was this connection between the community and then the health system. So it make it very difficult, and there were a lot of myth between the community dwellers about the health system. So after the Ebola, Liberia took that as a lesson learned and agreed that and come up with a standardized national community health program that was launched in 2016, focusing on community outside 5 kilometers. And this category was called the CHA. And Liberia was intentional to ensure that this CHA is being created to support the fight, specifically prevention and care of malaria in Liberia, to ensure that continuation of care and make sure that vulnerable population outside 5 kilometers are being served. Next. And then in 2023, Liberia also ensured that to be able to work in line with WHO agreement on universal health coverage, Liberia decided to also look at communities that are within 5 kilometers, which constitute 71% of the population, to ensure that there is a community health system in those urban communities, to make sure that those community health workers are not providing curative because of the distances, because of the proximity to the health facility, but they are able to provide curative, preventive and promotive services to ensure that linkages to care are improved. So Liberia was lucky to have the International Test Symposium, CAW Symposium in Liberia in March 2023. Liberia used this opportunity to be able to launch the new cadre of community health worker program, which Partners in Health supported and initiated and designed this program with the Ministry of Health. And then in that symposium, there was a lot of commitment called the Morovia Call to Action, wherein the government of Liberia committed to support and strengthen the sustainability of community health worker program in Liberia, because they have seen the impact the community health workers have made so far. So today in Liberia, we have a two cadre of community health workers, the one providing services outside 5 kilometers, and then one providing services within 5 kilometers. They are paid separately. Within 5 kilometers, receive incentives of 50 USD, and then the one outside 5 kilometers receive $70 as well. They also receive supplies like ring gear and backpack and other reporting tools to be able to do their work with that. Next slide. So you're going to see the distribution of the two community health cadre in Liberia, which shows you that the CHP yet to be scaled up. Funding from the government will support that to make sure that the CHP program is scaled up to other parts of the country. So far, we have the CHA across the country. The ministry has a target of 5,000 community health worker program, community health workers for the CHA. And then for the CHP, they are targeting 7,000 for that. When the funding is available, those community health workers will be recruited and trained and deployed into the communities. Next. These community health workers, when they are providing services doing their routine hospital visit, they have a job aid where they utilize that job aid to create awareness on specific diseases. And they also have a screening tools where they screen community members, specifically focusing on the RCCM program, the malaria, the pneumonia, and diarrhea, and then screen and identify those kids below 13 years old. Identify them and screen them, and then do our RODT, malaria rapid diagnosis test, to make sure that if the test read positive, they receive treatment, and then we refer these kids to the facility for further management. And for the severe cases, or complicated cases, they ensure that those cases are being escorted to the facility for proper management. And these tests that they do in the community and the treatment they provide in the community are also recorded, and they are being supervised by a structure, a robust supervisory structure that takes into consideration recording all of these necessary information that being gathered at the community level. Next. Liberia has a malaria profile, which is unique. To let you know some of these, Liberia has 15 administrative regions with the population of 5.3 million population. And then the population is also considered as population at risk for malaria, because Liberia is malaria endemic country. And then the prevalence of malaria in Liberia is around 45%. And then for the incident, is around 177 per 1,000 in the general population. Next. And then when it comes to the vector and the parasites for malaria, you have the Plasmodium, and then you also have the Anopheles gambis. Next, to show some burdens on the malaria effect in Liberia. Malaria is considered one of the leading causes of consultation, where people had to go to the facility to seek care, and one of the highest when it comes to inpatient death as well. So these are statistics of malaria cases over the years that have been able to be managed at the facility level and also at the community level. So 29% of the consultation in Liberia in the health system are due to malaria cases. Next. So when it comes to Liberia making effort, Liberia has a national strategic plan, which runs from 2021 to 2025. And the goal of this is to ensure that malaria reduction in case incidents is being reduced, and then the prevalence is also being reduced, and also to maintain and promote a culture of evidence-based decision-making to achieve malaria programs performance at all levels. Next. So for the CHP program, which is yet to be scaled up, is for now in one of the regions, Maryland, where Partners in Health has been able to support the Ministry of Health to ensure that this program is successful and show results that need to be replicated in other parts of the country, has been able to show tremendous impact with regard to the community health worker linking people to care. In 2021, all of the total consultation at the referral hospital, 15% of the cases that attended the facility were being linked to the facility, either through referral or escort, and this was done by the community health workers called the CHPs. In 2022, 17%, and then in 2023, 16% of the people who attended the facility were being referred or linked to the facility. Next. For malaria care and treatment, this is to show that the total malaria cases in Liberia versus the total malaria cases that were confirmed. The reason for this is that there are clinically treated malaria, probably due to the inability to have access to diagnostic tools where the patient present with all cardinal signs and symptoms. And to save life, the clinician will provide treatment for that. Next slide. And then this other slide is all about showing the burden of total malaria cases that were confirmed. And out of the total malaria cases that were confirmed in the country, what percentage, which is around 12%, confirmation by malaria RDT was done by the community health workers. So you can imagine how hugely the community health workers have been able to support the fight of malaria by confirming 12% of all confirmatory diagnoses of malaria. Next. For this other slide, we are trying to compare all malaria versus malaria in children under 5 years, which is around 38% of all malaria cases. 38% of them are considered cases of under 5 children. And then next. And then the next one is trying to show you the under 5 malaria cases that have been treated over the years. You have yearly average of 27% of all under 5 malaria cases being treated by the community health workers. And then next, you also have the treatment by the community health workers to show that the community health worker has been trusted and relied on by the community members. This trend shows that the community health workers are always at the doorstep whenever the child is being noticed with fever. Mothers will call upon them or doing their routine household visit. They are able to visit the household, screen the kids for fever, and then identify them, and then be able to treat them within 24 hours. So you have the greatest number of malaria cases are being treated within 24 hours, and then fewer cases are being treated after 24 hours by the community health worker. So they show that how trustworthy they are in the community and how they have been able to save lives. Next. So this is just to show that the overall malaria burden versus malaria death over the years. And this is showing that there's a decline when you compare 2017 to 2021. 2017, you have 914 cases, and then you have 300 being reduced at the level of community health workers so far, based on their effort. And then the last one is that next step, which is the last one, talk about the challenges. And most of these challenges are being to inform you to say that the fight of malaria is being supported by PMR, President Malaria Initiative, Global Fund, and sometimes the World Bank. And then the government of Liberia has been able to give some minimal support to the fight of malaria. And the community health workers are currently making all of these different impact are hugely being incentivized through the donor funding. So this makes it very difficult if those donor funding were away. How can Liberia be able to sustain these community health workers to continue to sustain the great work that they have done? Like I mentioned during the symposium, there was this Monrovia declaration where the government came in to make some commitment because they want to make sure that sustainability is key, is undertaken by the government. But as you all know, most of the African countries, the physical space are tight to be able to allow them to be able to support, to ensure, to improve sustainability in terms of the fight of diseases in the country. Next slide. These two types of community health workers will need training, and then they will also need vigorous supervision, which costs money. And in order to do that, the government of any country need to give support to ensure that the training are sufficient for them to be able to professionalize them, and then they are able to be retained, and then the supervisor cadre can be able to supervise and mentor them as well. And most of the time, Liberia community health workers fall short of supplies, either the RODT, the rapid diagnostic text tools, or they supply the actual drugs to be able to treat kids. Sometimes they have enough diagnostic tools, but the medication are out. So they identify and then they refer these cases. Sometimes they have the drugs, but then they are also out of the supply. So in order to make sure that they continue to increase the trend of improvement, there must be a way, opportunity to ensure that there is a strong supply chain system to make sure that the supply of the drugs as well as the test kits are available at all times in the country to be able to fight malaria as well. My last slide is showing that community health workers making a hospital visit where they screen and provide health talk during a routine visit, and the supervisor is sitting there looking on to make sure that the CHP conduct this awareness section correctly, and then it being buttressed by the supervisor as well. So far, thank you.
Thank you so much. It was absolutely fantastic to hear about the specific experience in Liberia. And I think that's incredibly valuable for the wider group to see, especially some of the data that you shared on salaries and just how the community health workers across both cadre are actually being remunerated. It's really important to see. I was watching the chat come in as you were talking, and there were repeated questions about sustainability of this type of programming, not just in Liberia, but across the continent. So I'm giving a little bit of a nudge to our panelists that we'll be coming back to the question of sustainability of these programs across the board when we go into the discussion. So our last, but certainly not least, panelist today is Harriet Napier, who serves as Senior Program Manager for Community Health on the Global Malaria Team at Clinton Health Access Initiative, CHI. Harriet has over 10 years of experience working with NGOs and governments to design and implement strong CHW programs. In her current capacity, she supports countries across Sub-Saharan Africa, the Greater Mekong subregion, Mesoamerica, and Hispaniola to holistically engage CHWs as key partners in the fight to eliminate malaria and improve access to basic health services. She oversees CHI's emerging portfolio of work at the intersection of malaria, gender, and community co-creation, which we've heard quite a bit about across the course of this conversation. And Harriet has served as a regular winter term faculty in the anthropology department and global health program at Middlebury College for the last 5 years. She holds degrees in public health and anthropology. I did not know that about you, Harriet. How interesting. Thank you for joining us, and over to you to give the final presentation before we open the floor.
Thanks very much. And can you just confirm that you see my slideshow and presenter mode? Okay, fantastic. Great. Well, thank you so much. Thanks for that kind introduction, and happy to be here with everyone today. I'm going to talk about improving the management of community health workers, and I'll highlight a couple examples that I'm particularly excited about that I think we can learn from. So tackling malaria requires consideration of access to care and quality of care bottlenecks across what we refer to as an effective coverage cascade. And what does this effective coverage cascade demonstrate? In short, that comprehensive malaria case management is complicated, right? And that progress towards improved malaria case management actually requires attention to multiple stages along this process. So we need to attend to kind of multiple steps along this cascade and do so in a way that really reflects an understanding of local context. So for example, let's start with kind of proportions across this cascade. So where are we losing the most people, right? For instance, are we seeing 40% or 90% of symptomatic patients seeking care? Of those who seek care, what percent are receiving an RDT? And does this percent vary by provider type? Typically it does, right? Of those who are tested and test positive, what proportion are receiving an anti-malaria, right? And then finally, what percent are receiving that ACT and completing the course of treatment, right? So we want to know, where are we losing the most people along this cascade of care, and then we want to respond accordingly. In addition to addressing who we are losing across this cascade of care, we're also interested in the time lags between these stages. So what percent of caregivers are seeking care for an ill child within 24 hours of symptom onset? Are those who receive, are those who seek care, are they promptly receiving a test? And of those who test positive, is there a delay before treatment is initiated? Because we know that the larger these time lags, right, the greater opportunity for malaria transmission and development of severe illness, as well as the greater risk for development of drug resistance. So a key takeaway from this effective coverage cascade is that there are really multiple different entry points for improving malaria case management. And these entry points are sort of of variable importance depending on the setting. So why am I going into this? We engage community health workers specifically because they're really uniquely positioned to address a number of different bottlenecks or obstacles across this cascade of care, and also to reduce some of these delays that I was mentioning between different stages along this cascade. I'm going to just kind of highlight a couple of those different bottlenecks that are important, both in terms of access to care and also service quality. So community health workers can uniquely address a number of these barriers, of course, including distance to care, right, being members of the communities where care is needed and provided. They can address also opportunity costs, right, by being closer to the community and having services that are more readily accessible. And then also issues around language, right? Language barriers. There may be certain barriers that make it challenging for certain patient populations to access care. However, in order for them to be able to do this effectively, we as their technical and management and policy partners need to make sure that they have the tools that they require to A, provide care, good care consistently, and B, really foster a relationship of mutual trust and respect with community members. So I like to think that this service quality bottleneck is often much more so a reflection of health system strength and also the strength of program management really than anything else. Let's dive into a couple examples of where we've seen community health workers make really impressive contributions to malaria case management across this cascade of care, or this effective coverage framework that I introduced. And then I'm going to speak a little bit briefly to some of the management strengths that we've observed across these three programs. We're going to look at the Dominican Republic, Zimbabwe, and Cambodia. So we'll start with the DR, and then we will head east. So in the Dominican Republic, the DR is a country with a very near-term malaria elimination goal. And in 2019, a small government-owned community health worker network of just 70 community health workers was initiated in Greater Santo Domingo. Progress since the initiation of this program has been really incredibly impressive. Community health workers between 2019 and 2023 were detecting malaria cases and initiating treatment a day and a half earlier than other health system entities. So again, I'm thinking about kind of this very early stage on the cascade of care, or the effective coverage framework. 96% of cases detected by community health workers were administered treatment within the first 24 hours. Interestingly, 83% of the cases detected by community health workers were actually detected through proactive case detection. So a very small proportion were detected passively. So again, this difference is essentially community health workers going door to door and saying, excuse me, does anybody here have a fever or is sick, versus passively, meaning patients are coming to the community health worker on their own accord. The result of this program between 2019 and 2023 was a reduction of malaria in foci where CHWs were introduced by 99.6%. So really very exciting progress in a quite short period of time. So I asked my colleague who's worked closely with the National Malaria Control Program, what has enabled these results? And she had some interesting feedback that speaks both to this effective coverage cascade as well as to some of the features of program management. She shared that it has been observed that when experiencing fever, people tend to stay home and self-medicate during the first 3 days. And this is due to the fact that historically people have been educated to seek dengue diagnosis after 3 days of fever. So what she reflects is that having somebody come and knock on the door and ask if there's fever in the house is really facilitating the possibility of early diagnosis in a way that a passive community health worker system might not. She also referenced that strong linkage between the community health worker network and the malaria program has been a really important feature of program success. Community health workers are assigned to a health facility in their community, and they're also supervised and supported by the local Ministry of Health. And this provides them with the support they need, as well as a sense of belonging, a validation that they are part of the health system. Let's move quickly to look at the program in Zimbabwe. So in Zimbabwe, we've also seen really impressive contributions of community health workers across this malaria effective coverage cascade. This is a much larger program. So across the country, there are around 17,000 village health workers, and their overall contribution to malaria care has increased significantly over the past 5 years, from about 40% in 2019 to just over 50% in 2020 to now almost 60% in 2023. And interestingly, there were some peaks in CHW contribution during the COVID outbreak, which also to me indicates that there's some strong investments in management of community health workers to protect them from health system shock. So I spoke again with my colleagues who have worked closely in supporting this program and asked them, again, what has enabled these results? Why are we seeing such effective and impressive contributions of CHWs along this cascade? And I had a couple points raised to me. One was around really improved data systems that has enabled more accurate capturing of CHW contributions to malaria. Secondly, provision of cell phones. So providing CHWs with cell phones has improved their capacity to communicate with health facility staff, and also provided an alternate mode of reporting, which was incredibly helpful, particularly during COVID, when visiting the health facility was possibly a bit more complicated for a number of different reasons. There's also just been, on a very basic level, pretty solid coverage of community case management for malaria training and good retention of community health workers over time, which has enabled this strong community relationship of trust. Finally, I'm just going to take a minute to talk about the program in Cambodia, which is another really fascinating example of immense contribution by community health workers. So village malaria workers in Cambodia are now conducting 77% of all malaria tests in country and identifying the vast majority of malaria cases. You'll see on the right here, I'm not going to dive into the detail of these graphs given time, but really interesting sort of ebb and flow and just really granular data showing the contributions of community health workers over time. This is a program of about 4,000 CHWs that was launched in 2004. In 2022, an interesting sort of change was made to the management of the program, where village malaria workers were actually provided with an additional incentive to accompany patients from the community to the health facility. And this was to enable something called G6PD testing, which allows patients to safely take primaquine as part of the radical cure for P. vivax malaria. In 2023, like I mentioned, CHWs are now providing 77% of malaria tests and diagnosing 62% of the cases. We have incredibly low positivity rate. It's well under 1%. So what has enabled these results in Cambodia? A couple different features of the program. The program design is really oriented towards the specific behaviors and exposures of the at-risk population. So, for example, we have a lot of the remaining P. vivax malaria in forest-going populations. So the village malaria program has really oriented towards going out and providing mobile care to those forest goers. There's very strong linkages between the VMWs and the health facilities. Like I mentioned, the referrals for vivax malaria are tracked and they're incentivized. And management processes are really adequately supported from both financial and HR perspectives. And again, they're carefully tracked. So I think what indicates this is looking at some of the data, right? We have 100% of the village malaria worker monthly meetings are taking place with 99% attendance, and 85% of the community health workers or village malaria workers are receiving their incentive payments on the day of the meeting using electronic payment. So great tracking of implementation. And when we look at the data that's coming out of this tracking, we're seeing that the implementation is happening as it should be, as it's intended. So what can we learn from these experiences? Again, community health workers are really uniquely positioned to address case management bottlenecks and delays to malaria care across this effective coverage cascade. And that includes reducing the time between symptom onset and diagnosis, and then also all the way to the end of this cascade, ensuring that we have higher rates of radical cure, which is going to drive down malaria overall. Sound program design and strong management systems that reach the last mile are just absolutely critical prerequisites to seeing success. It's not uncommon, right, for community health workers to provide the majority of malaria care. We see this in a lot of settings. We need to count CHWs, and a number of these points have already been raised by previous speakers. Geo-referenced community health worker master lists and data integration into DHIS2 or whatever the HMIS system is can help ensure that support is provided to the community health workers and that their contribution is acknowledged. In many settings, we're seeing a large drop-off early on in the cascade of care, and proactive household visitation is really a promising strategy. More frequent touch points with community health workers might help track and improve implementation fidelity, which is a very important piece to be monitoring. Mobile payments, right, that we've seen from a couple settings can help shield programs from some, but not all health system shocks, right? And then finally, strong subnational program ownership is increasing program resiliency, and it also promotes local adaptation, right? We don't want to see one-size-fits-all solutions introduced, but really looking at what is the community health worker program that's needed for this context, for this community, for this health system, and going from there. Thanks so much.
Thanks, Harriet. That was fabulous and a nice slide for us to end on. We have about 5 minutes left, and there are 22 questions in the chat. So we're not going to go line by line, but we'll make sure that we produce some feedback to the 125 people who have joined this call to address some of those really salient questions. What I would like to do, though, is I'd like to turn it over to the panelists just to close us out, maybe 1 minute per speaker. Margaret, if you're still on the line, I'd love to start with you, but maybe just your final thoughts on your hopes for CHWs and the CHW effort, let's say short term, let's say in the next year. What would you like to see happen? We might have lost her. Maureen, are you still there? You're next on my list.
We can move to Maureen then, and Margaret can join.
Lassana, you are the only panelist on the line that I can see, so I'll pose the question to you. What would you like to see happen in Liberia with the CHW program over the coming year?
Yes, so I would love to see how much the government of Liberia domestic funding can be increased for health and make specific emphasis in looking at improving and coming up with strategies to sustain the community health worker program. This might not just be direct funding, but there are other different government branches that can also contribute towards this. For example, we have Ministry of Youth and Sport, we have Ministry of Gender, we have Ministry of Education. All these different ministries, they have yearly funding. So how much of their yearly funding can contribute towards strengthening and supporting the community health worker program? For example, the gender ministry may say that, okay, all the female community health worker program can enroll on their payroll. And the youth ministries should say all of the different youth cadre of the community health program can also benefit from the youth program. That will, there's strong integration in sustaining the program rather than getting funding from the donor to be able to sustain this. I would love to see that happening in Liberia. And maybe we can share this lesson with all other countries and how we make it possible. Thank you.
Thank you. Thank you. Professor Ansah, your final closing remarks, please.
I would actually like to see all of these best practices and lessons that are being learned across the region and across various settings pulled together so that other countries can decide on what best fits their context and learn the lessons, because then they will know what works and what does not work and what will work in their context. So I would really like to see such a thing happen.
I think that sounds like an assignment for us. Margaret, final remarks from you?
Okay, my final remarks is it's such an honor now to bring community health workers on board, because there was a time that you were being represented by doctors and nurses and other people, and we were being misrepresented because they didn't know what happens on the ground. So my call to the leaders is just to make that equity in distribution of resources and funds nationally, especially in Kenya, so that every community health worker will get a standardized stipend for now, but we are heading to a salaried community health worker. That is what we are advocating for. And another issue is for the training. We need to have a constant updates on training, especially in malaria. It's such a long time since we had updates on malaria. And when we have a pandemic, when you have an issue pending, other pandemics will be addressed, and malaria will still be one of the most one of the diseases that kills people most, especially in Kenya, for children below 5 years and the people who are immunocompromised. So it is very important to have frequent training so that we may be updated as community health promoters. Also, another thing I would like to emphasize is that let's have a supplied community health promoter, because when you supply me with essential commodities, it will save a life, it will save time, and it is also save a life. Malaria is the central part of many other diseases like sickle cell anemia. When somebody is anemic, malaria will definitely be counted in on the lineup. When people have HIV, like people like us, malaria is one of the counted diseases that can kill for like so malaria is one of the killer diseases that should be taken very seriously, because this time malaria has been taken like it's a silent killer. It's a silent killer. It kills very quickly. So one thing I would like to just emphasize is as critical role as community health workers play, let us be supplied, because we will be able to detect and respond diseases like malaria very fast, and we will save lives and time also. In situations like the one we are in Kenya, Kenya is in a very dire situation right now health-wise. And if community health workers are going to be trained, they are going to be people who are now laying in bed because we have issues with the doctor. If community health workers are given enough training, they are going to save lives, even in the dire situations like this. We work with passion. Passion comes first, and then we advocate for us as a community health workers as we work. So in the situations like this, community health workers play a very, very vital role. So yes, protect community health workers, study community health workers, and supply community health workers, because that is the main gap that's remaining in the fraternity. That is the gap that people are asking. What have we done wrong? What people have, the health fraternity have done wrong is they have an unsupplied, unprotected, and unpaid community health worker, whom 70% of these community health workers are women. So if this gap is going to be filled, then we are going to be having a very strong global health security. Thank you.
Thank you so much, Margaret. I hope Harriet and Maureen will forgive me, but we're over time, and I feel like it's only appropriate that we end with the wise words of our resident community health worker. Margaret, thank you so much for joining us from where you are. And thank you so much to all of the people who were able to participate in this extremely valuable webinar. Nana, I pass it back to you as the organizer to close. Thank you for letting me join this conversation.
Thank you very much, Abigail. Thank you very much to all of you. It's been a very, very, very good session, and I think there's nothing more for me to say but to highlight the critical workforce that community health workers are, and that if they are treated as professionals and are well integrated in the national health systems, there's going to be an enormous potential to extend healthcare services to those who need them most. And without saying any more, thank you very much to all our speakers for making this possible in the preparation and all your contribution to making this a successful event. And we hope to do more things, not just stop here, in making a change in professionalizing community health workers. Thank you all very much. And you can follow us on social media. We'll put the YouTube recording there as well. Thank you very much.
Bye-bye.
Thank you, everyone.